And with that, I'm going to introduce the first speaker, Dr. Erik Musiek, who is the Charlotte and Paul Hageman Professor of Neurology at Washington University in St. Louis. And he's the co-director of the Center on Biological Rhythms in Sleep, COBRAS. I know, Erik, you had a lot of fun coming up with that name. And with that, I'll give you the podium.
All right, thank you, Percy, and thank you for the invitation. I'm excited to be here. I will say up front that I have chosen Alzheimer's disease as sort of my index neurodegenerative disease because it's too much to cover in 10 minutes otherwise. And I think we know the most about Alzheimer's disease and how it relates to sleep and circadian rhythm, but many of these same lessons apply to Parkinson's disease, Huntington's, many other neurodegenerative diseases that we could talk about later. Also, I usually give this talk in about 30 minutes, so I had to cut most of my slides, so many people in this room, I probably cut out important contributions that you've made to the field, and I apologize about that. So it's really kind of a sampling of the data. But there really is quite a bit of data accumulating related to sleep and circadian rhythms in Alzheimer's disease. One disclosure, I do have research funding from Eisai Pharmaceuticals. Where's Marge here? Work directly with Marge on some work, but no other like personal financial disclosures. So we've known for a long time that people with Alzheimer's disease dementia, so symptomatic Alzheimer's disease, have sleep and circadian dysfunction or problems. And in fact, in the clinic, we hear about this all the time. It's a major cause of institutionalization for patients. And there's kind of a wide range of problems that people can have. They can have poor sleep efficiency. They can have increased napping. They have decreased slow wave sleep. They have decreased REM sleep. And they have this fragmented pattern of sleep where they tend to nap and sleep more during the day and be awake more at night. They can also have a phase delay, meaning that their activity peak is a few hours later than normal. And this is thought to potentially contribute to this phenomenon of sundowning, in which people become more confused later in the day, although that hasn't been entirely proven. So this is actigraphy from patients with Alzheimer's disease from this Brain paper 2004, showing that there's sort of a breakdown of their normal nice day-night actigraphy pattern to a point where you almost can't recognize days and nights in some of these patients. And there's a degeneration of the suprachiasmatic nucleus. In fact, Cliff Saper's group has shown that there's a direct correlation between the number of neurons, VIP-ergic and AVP-ergic neurons in the SCN and people's circadian function before they died. So once you have the disease and you have degeneration of your brain, there's clearly problems. But one of the major questions that we're interested in, maybe many others are interested in, is this a chicken or is this the egg? Is sleep dysfunction, circadian dysfunction causing the disease, or is it just simply a result of brain degeneration? I'd say we haven't answered that question yet, but I'm going to show you some data supporting the idea that it may be some of both. So probably the most interesting epidemiologic data that we have in this area comes from the Whitehall study, where they, in England, followed people for many, many years, I guess public servants, and asked them questions about all aspects of their health, and then monitored them over time. I'm sorry, I'm skipping ahead. So essentially from that study and from a bunch of other studies has emerged this sort of relationship between people's reported sleep time and their risk of Alzheimer's disease, or risk of dementia in many cases. It's not specifically Alzheimer's disease. And it sort of has this U-shaped curve in that people who report, and most of this is all just self-report, people that report low amounts of sleep each night have a higher risk of later developing Alzheimer's disease. And then there's some data that people that report a lot of sleep at night maybe have a slightly higher risk as well. So this is sort of an interesting phenomenon where it seems if you're kind of in the normal range, then maybe your risk is essentially kind of flat, but if you start to sleep less, then you may have more risk. And as I was mentioning this Whitehall study, this paper kind of gets at this question of whether or not sleep disruption in midlife actually has an impact on your risk of Alzheimer's disease later on. So what they found in this paper, by following people for a long period of time, 25 plus years, is that people that reported, oh no, wrong button, sorry, there we go. People that reported low sleep, less than 6 hours of sleep when they were age 50, had about a 1.28 relative risk of developing dementia later on, so 25, 30 years later. And why is this important? Well, it's important because the pathology in the brain in Alzheimer's disease actually occurs maybe 15 to 20 years prior to the symptom onset. So unless you have a really long follow-up, it's very hard to disentangle which effects of sleep and circadian rhythms are due to accumulating preclinical disease, meaning you have the changes in your brain of Alzheimer's, versus causality. So having this causality, you really need this very long window to know that these people probably didn't have plaques and tangles in their brain at the time when they were reporting sleep problems. So, and if you look at age 60, the people reporting low sleep had an even higher relative risk of developing dementia in the future. So this is kind of the most epidemiologic data we have, looking way back into people, 30 years prior to developing dementia, saying that there's some signal there that maybe at least self-reported sleep may put you at higher risk. Now, as we know, self-reported sleep isn't necessarily always accurate. There's no biomarkers in this study, so we don't know if some of these people already had plaques and tangles in their brains, but this is probably as good as it gets at this point. So we also know that people that have these Alzheimer's-related brain changes but don't have symptoms yet, so this preclinical phase of disease, when you have plaques and tangles in your brain but you don't have any memory problems, that those people do have sleep abnormalities. So my colleague at WashU, Yoel Ju, looked at this. So you can basically use these different AD biomarkers. You can either look at cerebrospinal fluid, amyloid beta, and tau, or there's PET imaging methods to see these plaques in the brain years before people have any symptoms. And so all of these studies take cognitively normal people who don't have any symptoms but have positive biomarkers, so they have these Alzheimer's-related changes in their brain, and show that they have abnormalities in sleep. So the people that have positive biomarkers for Alzheimer's disease are more likely to have poor sleep efficiency. There's a correlation between these spinal fluid biomarkers and sleep problems. This paper, they looked at a lot of different things, somnolence, whatever sleep problems index is. And then Joe Weiner showed that there's actually a relationship between amyloid PET uptake in the frontal lobe and slow wave sleep, that there's a diminishment there. So there are actually a bunch of other papers that I didn't show, and there's more every day showing that people that have this preclinical phase of Alzheimer's disease do have sleep abnormalities. So this is at least happening early in the course of the disease. And the same holds true for circadian dysfunction. So our group looked at this in about 200 patients who were cognitively normal that had spinal fluid biomarkers, and people that had positive biomarkers were more likely to have disrupted circadian rhythms. So this thing called intradaily variability, which is it's a measurement of fragmentation of your daily rhythm. It correlates pretty well with the spinal fluid amyloid beta tau biomarkers. So this means more Alzheimer's disease pathology, and this means more fragmented circadian rhythm, and there's a relationship. Kun-Hu's group at Harvard looked at patients that were all cognitively normal, and they did actigraphy on them every year for 14 years, and found that the people that had either low amplitude or more fragmentation of their circadian rhythms were more likely to develop dementia during that time. So it seems as though once you start to get these plaques and tangles, you do start to get some sort of fragmentation or sleep. And actually, if you notice that some of the sleep measurements that were looked at, like sleep efficiency and napping, they're kind of related to this fragmentation phenotype. They probably are the same thing. But we don't know where this happens in the course of the disease. I mean, this is a 20-year period where people are developing pathology. We don't exactly know where in that period the people start to develop this. And we don't know if before that, if people are having sleep problems before that. So we now have a study going on at WashU where we have recruited about 200 people who were cognitively normal and biomarker negative, and now we've followed them for 15 years. And we're going to see the people that had poor sleep, poor circadian function at the beginning, are they more likely to develop plaques, develop tangles, to kind of get at that question, but we're not quite there yet. So thinking about mechanisms a little bit, how could this potentially impact the disease? So if you have these things, who cares? Why does it matter? Well, I think Dave Holtzman's group was kind of the first to show in mice that this can have quite an impact. And one of the most striking things that Holtzman's group found that is, if you look at the extracellular fluid in the brain, that there's these really beautiful diurnal, really circadian rhythms in amyloid beta levels. So amyloid beta peptide is what forms these amyloid plaques, and it's the target of most of our new upcoming Alzheimer's drugs. And there's this clear relationship between amyloid beta levels in the brain, and this is wake. So when the animal's awake, there's a lot of A beta. When it goes to sleep, A beta goes down. And this has actually been shown in humans as well by Randy Bateman's group using lumbar catheters. And then Dave Holtzman's group showed that if you sleep deprive the mice, they will develop more plaques. So these are genetically engineered mice. They're APP-PS1 transgenic mice that get plaques, but if you sleep deprive them, they get plaques even faster, which is quite impressive. You see the black bars, kind of all different areas of the brain. The mice develop more plaque if you sleep deprive them for 2 months. And then Brendan Lucy, another colleague at WashU, has now looked at this in humans using lumbar catheters, collecting spinal fluid every hour in people that are in the lab and measuring amyloid beta in the cerebrospinal fluid from humans. And what he showed, and he has a lot of data, actually very similar data for tau as well, that the red bar is people that were sleep deprived. So you can see this is when they go to sleep. Normally your amyloid beta levels stay about the same over the course of the night, but if you're sleep deprived, your amyloid beta levels in your spinal fluid actually go up. Interestingly, the green bars are sodium oxybate, so they're actually increasing sleep in these people, and it didn't seem to lower A beta. So it suggests that the brain may be able to deal with A beta under normal sleep conditions, but if you're totally sleep deprived, it cannot. Now, an interesting point from this is that Brendan's group, is that my 11 minutes already? Oh boy, I'm way over. I better keep going. I'm going to have to skip some stuff. So I would be remiss if I didn't mention the glymphatic system, which is a movement of fluid through the brain that Maka Nadergaard's group has found, that this can remove amyloid beta, tau, synuclein, and other things from the brain during sleep. So when animals sleep, they have more of this fluid flow. And so there's a debate in the field, and I'm going to skip ahead, actually, to my questions. And I have to skip a lot of my own work, unfortunately, but that's okay. What are the main questions? So this chicken or the egg question, which comes first? Circadian dysfunction, sleep, or pathology, or both? We don't know that yet, but I mentioned that a lot. What aspects of sleep or circadian rhythms are really important? What's the detrimental thing? Is it the loss of slow wave sleep? Is it this fragmentation? Is it some REM effect? We don't know that. Is it a purely circadian effect? What are the mechanisms? So there's a debate about whether or not sleep causes clearance or decreases production. This was mentioned yesterday. It could do both. Dave Holtzman would argue production. Maka Nadergaard would argue clearance. There's evidence for both. Which is more important? And then how do we target this? So I didn't show some data, but orexin antagonists seem to be very effective at preventing plaque formation in mice. And so is there something special about orexin antagonists? Is it all sleep agents that are going to have this protective effect against plaques? We don't know, but I think that's a critical question. So sorry for going over, and thank you for the opportunity.
Thank you, Erik.